So today's class is on thyroid disease. It's a bit of a long topic, so I'll try to do it a bit slowly, but try to cover the main points as well. Okay, so this can be also the MCQ, SCQ, and the long and short cases. Everything can come. Okay, it's common, and they can give it for everything. Okay, so thyroid diseases, there's a lot. I'm mainly focusing on the malignancies. Okay, like the breast class, thyroid also I'll focus mostly on the malignancies because that's what they'll also focus mostly on, especially with the types of malignancies and the pre-op and the post-op. Okay, then during the class, I'll tell you all about the MCQ points, and we'll go through the history and examination of the victim. When we take a goiter, the definition of a goiter is a lump or swelling on the front of the neck caused by a swollen thyroid. Okay, so this goiter also, there's a WHO classification of the goiter depending on how palpable it is and how visible it is, right? So grade 0 is not palpable, nor is it visible. Grade 1, so the normal thyroid gland is not palpable, neither is it visible. Okay, so that is an MCQ, I think, because there's some. Grade 1A is a goiter which is palpable but not visible. Okay. Grade 1B, the goiter is palpable and visible only on extension of the neck. Okay. Grade 2 is goiter is palpable and visible without extension of the neck, mainly at close proximity. So you have to come close to notice it properly. Grade 3 is a goiter which is palpable and visible even at a distance, those big ones that you come across sometimes at the ward. Okay, so for the exam, especially short cases, you will usually they give a big one like grade 2 or grade 3, but if you're unlucky, you might get a 1B, something that is barely visible or maybe an extension of the neck. Usually grade 2 and 3, well, usually, okay? So if you can see it clearly from a distance, you can confidently say this is a grade 3 goiter. Okay. So types of goiter can be diffuse or nodular. If it is nodular, you can further classify it as a solitary nodule and multinodular goiter. Okay, so you need to know what gives rise to diffuse goiter and what gives rise to nodular goiter. Okay. So diffuse goiters are your simple colloid goiters, like endemic goiter. Now endemic goiter is mainly due to like iodine deficiency, but that's rare now because the salt is iodized. Okay, island-wide the salt is iodized, so iodine deficiency and endemic goiters are quite rare. Okay, then in cases where there's increased demand for thyroid hormone, increased metabolism, like your puberty, pregnancy, also you can get simple colloid goiters. And goitrogens, such as cabbage, manioc, can give rise. Theoretically, they can give rise to a goiter, but for you to get a goiter from just eating cabbage and manioc, you should eat it like so much, like every day for all the 3 meals or sometimes for years. Okay, so theoretically, yes, but you rarely come across cases like that. Graves' disease important. Okay, Graves' disease is a diffuse goiter which will present as hyperthyroidism, okay, which will have thyrotoxic features as well. Thyroiditis also can present as a diffuse goiter. Some types of thyroiditis can present as diffuse goiter. Some other types of thyroiditis can present as a nodular goiter. So thyroiditis in the early stages, there will be hyperthyroid features. Late stages, when there's destruction of the gland, you get hypothyroidism. Okay, simple colloid goiter, they can even be euthyroid, hyperthyroid, or even hypothyroid features may be there. Okay. Then when it comes to nodular goiter, solitary nodules. These are the DDs of a solitary nodule. So this is important. This can be asked, right? MCQ, SCQ, even Longcase, short cases can be asked. Okay, so solitary nodule, the first DD is, it could be a dominant nodule of a multinodular goiter. So you have a multinodular goiter, and if there's a huge nodule in that multinodular goiter, you can see it as a solitary nodule. So on examination, on inspection and palpation, you might miss the other small nodules, but you might only see and palpate this large nodule. So it can be one of the dominant nodules of a multinodular goiter. Okay. And another MCQ point is, in a solitary nodule, if a patient comes with a solitary nodule, the first investigation you should do is an ultrasound scan of the neck. Okay, to differentiate if it's a solitary nodule only or if it's a solitary nodule, if it's a dominant nodule of a multinodular goiter. So in an MCQ, I think there are quite a few MCQs where they've asked patient coming with neck and whatever lump on the anterior aspect of the neck, there's a solitary nodule, something like that. What would be the next best investigation for that? For the SBA question, the answer should be an ultrasound neck. Okay, not the thyroid function test. If it's a solitary nodule, the first investigation you should do is an ultrasound neck. Okay, for the MCQ purposes, the answer is ultrasound neck, but in practice, you write the thyroid function and then do the ultrasound. Okay, but for the MCQ answer, the best investigation is ultrasound neck. Okay. Then Hashimoto's thyroiditis can present as a solitary nodule. Thyroid cysts can present as a nodule. Tumors, thyroid tumors, adenomas, carcinomas, lymphomas can present as solitary nodules as well. Okay, so this part is very important, especially that SBA part I told you. If there's a solitary nodule, the best investigation is ultrasound neck. So the next investigation should be an ultrasound neck and not the thyroid function test. If it's any other diffuse goiter, multinodular goiter, then yes, then you can do a thyroid function test as the next investigation. But solitary nodule, next investigation should be ultrasound neck. Okay, so that has been asked quite a few times, so that's why I'm stressing on. Then multinodular goiter causes of multinodular goiters are late stages or advanced stages of endemic goiter. You can get a multinodular goiter. Initially, endemic goiters are diffuse, but later on, if it's untreated, it can progress to a multinodular goiter. And Plummer's disease. Plummer's disease is where there's a multinodular goiter with hyperthyroidism. Okay, so it's a toxic multinodular goiter known as Plummer's disease. Okay. Yeah. Then clinical assessment. This is for your long cases, and sometimes even in the SCQs they can ask you like features of invasion, right? Like malignant features. In the history, what would you look for? In the examination, what would you look for? I think there were 1 or 2 SCQs they've asked that. Okay, so you need to know what to check in the history and what to check in the examination, right? So I'll show you my note, right? So I couldn't type this out. I didn't have time, but it's not clear here. I'll scan it properly and send it again, okay? Hope everyone can see this. Okay, so thyroid history taking. So provided this is for the long case, okay? So at the exam, when you walk in, you will most likely see a patient with a neck lump. And these thyroid, the goiters and thyroid malignancies in general, they are common in females, okay? So that's also like another risk factor for these malignancies. So at the exam, if you see a patient with a neck lump, for the long case, okay, I don't think it's observed history taking yet. So for the long case, first ask the patient to swallow. If it moves with swallowing, you first confirm it's a goiter and then direct all the questions towards the goiter, okay? In the short case, you first have to do the inspection, you get the consent and all that. Okay, but long case, you just walk in, it's you and the patient. Before you even talk to the patient, ask the name and everything, just ask the patient to swallow, you figure out if it's a goiter or not, and then direct all the questions towards the goiter, okay? So the presenting complaint would be like an anterior neck, like swelling or lump in the front or the anterior aspect of the neck for this many months duration, like that. Okay, then there itself in the history of presenting complaint, you can say how she first noticed it and all that. Okay, so when we talk about the thyroid history taking, we have to ask about 3 basic components. Okay, we have to ask about the anatomy related questions, the physiology related questions, and the pathology related questions. Okay, what it means is anatomy related questions are your pressure symptoms. Okay, so pressure symptoms such as there can be facial congestion when there's sort of impairment of the venous drainage. Pressure symptoms to the trachea, there can be dyspnea, orthopnea. If there's pressure symptoms or if there's invasion of the esophagus, there can be dysphagia, right? And there can be changes in the voice. Okay, so these are what we ask for the anatomical symptoms, okay? So don't present it saying with regard to the anatomical symptoms, but just break it down into anatomy, physiology, and pathology, and put the sub questions under these topics, then you don't miss any. So on the anatomical related questions, you ask for pressure symptoms like facial congestion, dyspnea, orthopnea, dysphagia, changes in voice. But also remember, this change in voice can be due to multiple reasons in a patient with a goiter. Okay, one is it can be due to the pressure itself. Okay, like pressure and compression of the recurrent laryngeal nerves. Okay, it can also be due to malignant invasion into the recurrent laryngeal nerve. Okay, and also it could also be part of hypothyroidism. So if there's changes in voice, it's not always due to a pressure symptom. It's not always due to malignant invasion. It's not always due to hypothyroidism. It can be due to either of these reasons, right? So 3 reasons for changes in voice in a patient with a goiter: malignant invasion, hypothyroidism, and pressure symptoms. Okay. This pain part, you can put it to the pathology part. Okay. That's where there's invasion of the nerves and okay. So the anatomical symptoms are those: the pressure symptoms, facial congestion, dyspnea, orthopnea, dysphagia, voice changes. Physiological symptoms are your thyroid status, right? So when it's a goiter, you need to figure out if the patient is hyperthyroid or hypothyroid or euthyroid. Okay, so hyperthyroidism, I'm not going to go into so much detail. You all already know what the symptoms of hyperthyroidism and hypothyroidism are, right? But there are some cardinal features that you have to ask for each, like hyperthyroidism or hypothyroidism. So for hyperthyroidism, you need to ask about weight loss despite polyphagia. Okay, that means despite having an increased appetite, polyphagia means increased appetite, they still have a weight loss. Okay, heat intolerance. Okay, palpitations because of tachycardia, it could be atrial fibrillation, like that. Irritability and tremulousness. Ask at least these 4 or 5 questions for hyperthyroidism. Okay. Then if it's a female, like menstrual irregularities, but the menstrual irregularities can go either way. Okay. Then hypothyroidism, you need to ask at least for these 3: cold intolerance, lethargy, constipation. Okay. And then the other stuff, hoarseness of voice, I told you, can be part of hypothyroidism. So, like I said before, hyperthyroidism and hypothyroidism, there's a huge list of clinical features, but you might not have time to ask all that in 20 minutes. So ask the main ones, okay, at least 3 to 4 questions from each section to show the examiner that you like try to figure out if it's hyperthyroid or euthyroid. Okay. So yeah. So once you identify these, you can say that the patient is having weight loss despite increased appetite, there is heat intolerance, or you can, without using the medical terms, you can say that he's sweating when the others are not sweating, or when the others are feeling cold, he's still sweating, something like that. You put it in your own words and tell, therefore, he has clinical features of hyperthyroidism. So you can present like that. But sometimes when you've taken histories, you might have come across patients that say they have uh, features of both. Sometimes they say there's weight loss, but say they have constipation also, like that. Okay, so it's not always 100% hyperthyroidism features or 100% hypothyroid features. Sometimes they tell yes to all the questions you ask. So it's fine, you present it like that. But then you can say if both the hard signs for hyper and hypothyroidism are present, you can say clinically there's a mixed clinical picture of both hyper and hypothyroidism. Okay. Sometimes if there's neither any of these symptoms, you can say clinically the patient is euthyroid. Okay. So that's how we ask about the physiological status, like the thyroid status. Okay, first you ask about the anatomy, then you ask about the physiology, that's thyroid status, and then the pathology. Pathological features are basically the features of malignancy, right? Main features of malignancy are like your pain. Okay, pain, sudden increase in pain, pain radiating to the ear. Pain radiating to the ears because there's infiltration of the vagus nerve. Right? Then recent rapid enlargement can be a feature of malignancy, can be a feature of hemorrhage into a cyst also. Okay. Change in voice, I told you change in voice, the hoarseness of voice can be due to 3 reasons. But if it's like sudden onset, progressively worsening, highly likely due to a malignancy. Okay, that is because there's infiltration of recurrent laryngeal nerve. Okay. So Once again, you get the basic details, duration, onset, progression, and stuff like that. Okay. Then break down the symptoms in anatomical symptoms, physiological symptoms, and pathological symptoms, and put it on under those subtopics and present. And then the normal stuff, the systemic features of malignancy, your loss of appetite, loss of weight, lung, liver, brain, bones, spent. Okay. Ask about those. Then risk factors and etiologies you have to ask about, like any family history, especially family history is important in some malignancies. Radiation exposure in the past. Endemic goiter, you can ask about the salt intake and stuff, but like I said before, all the salt is iodized. If at all, you can ask about like when they add food to the salt, how they store the salt and stuff like that. Okay. Goitrogens, you can ask, but it's more of a theoretical risk, okay? With this cabbage and manioc and stuff. Okay. When it comes to DEDs, it's very straightforward, like an anterior neck clump with moves with deglutition and stuff. Most likely due to thyroid, but you can get sort of, it could even be lymph node, okay, like pretracheal lymph node enlargement, but they won't really move with deglutition. But you can just ask to exclude like lymphomas and stuff. Any other lumps noted elsewhere, like axillary lumps, groin lumps, okay. Branchial cystos is rare. There can be some bitter tasting discharge into the mouth, okay. So nothing much to ask for DEDs actually, okay. Yeah. And then what has the patient done up to now? The investigations, scans, and all that. Okay. Then the normal medical, surgical, drug allergy, family social history. Especially in the past medical history, you need to ask about asthma. Okay. For the past medical history, you need to ask about asthma, especially if the patient is hyperthyroid also. Because for hyperthyroidism, the management, you have to give antithyroid drugs like carbimazole, and for the symptoms, you have to give a beta blocker, right? But you can't give a beta blocker if the patient is having asthma. Okay. The alternative is to give a calcium channel blocker like diltiazem. So if there's a patient with a goiter and hyperthyroid features, in the past medical history, like you said, no diabetes, no hypertension, no dyslipidemia, better than saying those three, first say no history of asthma. Okay. If anyone asks why, you can justify, because you can say you need to give beta blockers for the management, but since this patient is having a history of asthma, beta blockers are contraindicated, then you have to give calcium channel blockers. Okay. Others are the basic format. Any questions in the history taking? Oh, that's clear. It's very basic history taking. Okay. Yeah. Then examination. There's inspection, palpation, percussion, auscultation. Okay, even for the thyroid examination to do all four, don't forget the four. Or in a stepwise manner, don't forget there is a percussion, there is an auscultation. And even for the short case, you have to do all this. If you don't have time, you can offer, but better to do. And you have to do a relevant general examination. Okay. The inspection is, I think you already know this. You should go down to the same level of the patient's neck, okay? Bend down properly, kneel down, whatever. Make sure you're like properly at eye level. Your eye is at the level of the thyroid, okay? And I think this is, you all know, don't just ask the patient to swallow, because after so many students have come and examined, there's nothing to swallow. So you need to give a glass of water. So they check all this, okay? They can cut marks if you don't give the glass of water, especially if it's there by the side of the patient. If it's not there, offer to give a glass of water bottle or something, and ask to take a sip and keep the water in the mouth. Okay, position yourself well to observe the neck. Then ask the patient to swallow the water. So once you give the glass of water, so don't tell her to swallow it immediately. Take a mouthful of water, keep it, and then you properly get down to the patient's neck level and ask to swallow, and then you can see it moving with deglutition. Okay, thyroids move with deglutition. Okay, so when you're inspecting, you need to comment on the symmetry or the asymmetry. Sometimes even the nodularity may be visible, okay? So you can say this is a symmetrical or like an asymmetrically enlarged goiter more towards the right side, and it appears to be nodular. Okay, if you can properly see it, some you can't see it, you need to palpate and see. Then overlying skin changes, if there are any overlying surgical scars, right? Sometimes it can be a patient who has undergone a hemithyroidectomy, right? So then one lobe of the thyroid is still there, like that. Overlying skin changes or scars. Okay. Visible pulsations, sometimes with hyperthyroidism, malignant goiters, you might have visible pulsations, especially if there's increased vascularity to the gland. Okay. Distended neck veins, and you can check Pemberton sinus. Okay. Pemberton sinus, where you ask the patient to raise both arms and wait for a few seconds. There can be like congestion of the face. Okay. That is inspection. Then palpation. On palpation, you need to ideally, most of them will expect you to go behind and palpate. Okay, so if you get Dr. Langa Pereira, definitely go behind and palpate. But sometimes examiners might even be okay with you palpating it from front, but most of us are used to palpating it from behind, right? So go from behind and palpate. Better to do that. Okay, so when you're palpating, also you need to stabilize the head. You need to always be gentle with the patient. You're palpating from behind, so you can't see the patient's face to see if there's pain or not, right? So before you go behind the patient, tell the patient you're going to go behind, you're going to palpate, ask if there's pain first, and reassure the patient. Tell she might feel some pressure in the neck, but don't worry. If it's painful, tell, and you'll stop. And just show that you are like concerned about the patient because you can't see the face, right? When you're going from behind. Okay. So when you're palpating, you need to palpate one side at a time, like right side and then left side, or left side and then right side, whatever is easy for you. Okay, so when you palpate, you need to be able to come to a conclusion on these 5 things. Okay, like you need to figure out whether it's a single lobe or both lobes are involved. Okay, whether it's right lobe, whether it's left lobe, both lobes, is the isthmus also involved, like that. The extension as in superiorly up to what extent does it has it enlarged, inferiorly up to what extent does it is it going retrosternally as well? Okay, then the surface consistency tenderness. Okay, surface is basically like smooth surface or like nodular. Smooth surface would be like a diffuse goiter. Nodular would be like a multinodular goiter. And if it's a multinodular goiter, you need to comment on whether you can feel a dominant vascularity of the gland. Those are like thrills. Okay, when you palpate, can you feel thrills? This point, even if you miss out on this, it's okay. Not that important, but if you feel a thrill, you can just tell. Okay. Then effect on neighboring structures also you need to definitely check, especially the lymph nodes. So you need to, when you're at the back itself, you need to check all the lymph nodes, the cervical lymph nodes, and carotid displays. Okay. So once again, the main 5 points you need to check on when you're palpating are what lobe is enlarged. Okay. And actually, before you go behind and palpate the thyroid, it's better if you can check the tracheal displacement first and go. Okay. There are a few reasons to do that. Before you go behind, it's better if you can check the tracheal displacement, because when you palpate the neck, you are palpating from in front, right? So if there's any pain, you can see if the patient is in pain or not. So that is one thing. And also, you can check the tracheal deviation. Okay, it's better to check the tracheal deviation before you go behind. That is because if you take the anatomy, the isthmus of the thyroid gland is always in front of the trachea. Okay, the right lobe of the thyroid is always to the right of the trachea, and left lobe of the thyroid gland is always to the left of the trachea. Okay, so when you're palpating for tracheal deviation, if you know that the trachea has deviated to the right, when you palpate from behind, you won't get confused, right? So what I recommend is better to palpate the tracheal deviation from in front and then go behind and palpate the thyroid. Okay. So yeah. Okay, so when you palpate from behind, if you feel like an enlargement on the right side of the trachea, you know that it's the right lobe. If you feel an enlargement on the left side of the trachea, it's the left lobe. And if you feel an enlargement in front of the trachea, that is more likely to be the isthmus. Okay. Then the extension. Like superiorly up to what extent does it go to? Like roughly give a level, like if you can feel it going up to the hyoid bone, say superiorly it extends up to the higher level of the hyoid bone, or superiorly it extends even above the hyoid bone. Then inferiorly, can you get below the lower border or not? If you can't get below the lower border, ask the patient to swallow and see if you can get below the lower border. Then if you still can't get below the lower border, that means it's extending much more retrosternally, okay? If you can't get below the lower border, that means there is retrosternal extension. Then you ask the patient to swallow. If you still can't get below the lower border, that means the retrosternal extension is much more. Okay, so you get a basic idea with that. Then consistency. Normally, the physiological consistency is soft. Okay, malignancies are firm. Hard, if it's hard, it could be a malignancy, mainly this anaplastic carcinoma, and also radial thyroiditis. Okay. Then the surface. If it's smooth, it could be a diffusely enlarged goiter. Okay. Irregular means there are multiple nodules. If it is smooth and you just feel a solitary nodule, it's a solitary nodule. Okay. And if you feel multiple nodules, try and palpate properly and comment to see if there's a prominent nodule. Okay, if you feel multiple nodules, palpate properly and try to find a dominant nodule. Okay, so when you're presenting, you can say it's a multinodular goiter with a dominant nodule on the right lobe, or dominant nodule on the isthmus, like that. Okay, and tenderness. So tenderness, you can't see the patient's facial expressions when you're palpating from behind, but when you're palpating, just ask if it's hurting or not. Okay. Vascularity, it's okay if you skip this step, but if you feel any obvious thrills, you can tell. Okay. An effect on the neighboring structures, mainly the lymph nodes and the carotid pulses. So lymph nodes, check all the cervical lymph nodes, and carotid pulses, check one at a time and see if it's displaced or not. Okay. Displaced carotid pulse or lack of a carotid pulse on one side is also known as Berry's sign. Okay. Then you come back to the front and check and percuss. Okay, percuss from bottom to top. You percuss from a resonant area to a dull area to assess retrosternal extension. Okay, but this percussion, so when you're palpating, if you can clearly get below the thyroid, that means there's no retrosternal extension, right? So then there's actually no point in percussing you. So you don't have to percuss if you can get below the lump. Say you, if it's a short case, say you don't need to percuss because there is no retrosternal extension on palpation. However, on palpation, if you can't get below the lump and there is retrosternal extension, then you can confirm the retrosternal extension by percussion. Okay. So when there's retrosternal extension, there's dullness. And then auscultation, you have to auscultate the superior poles on both sides. Okay. For bruits. Okay. So bruits can indicate like a hypermetabolic state or increased vascularity, okay, in like graves and stuff. Right. So that is the thyroid examination, and then the inspection, palpation, percussion, and auscultation. And then you can do the relevant general examination, mainly focusing again on the thyroid status and to look for features of distal metastasis. Okay. So just comment on whether the patient is well looking, thin, cachectic or not, irritable, sweating. Okay. Dyspnea could indicate tracheal compression. Okay. Irritability, sweating, features of hyperthyroidism, cachectic, maybe malignancy, maybe severe hyperthyroidism, okay, like thin. Okay. Facial edema can be due to hypothyroidism or even like venous congestion. Eye signs, okay, you need to look for exophthalmos, proptosis, lid lag with retraction, okay, ophthalmoplegia, checking the eye movements, and chemosis. So these eye signs, these are the eye signs, okay, so this is the pupil and this is the sclera, this is the eye, this is the sclera, this is the pupil. So normally this is what it looks like. Okay, so there's a small difference between proptosis and exophthalmos. It's not the same thing. Exophthalmos is when you can see the sclera below the pupil. Okay. The sclera below can be seen, that is exophthalmos. Lid retraction means when the sclera above can be seen. Okay. Basically, you get the patient to look straight. Okay, you don't get the patient to look up or down. Then obviously you can see the sclera above and below. Get the patient to look stay at a neutral position and look straight. So in that position, if you can see the sclera below, that is exophthalmos. Lid retraction is when you can see the sclera above the pupil. Okay. You can see the sclera above and below, that is exophthalmos and lid retraction. Proptosis is, for this again, you need to look from behind. So once you're done with the palpation, you can quickly look from top and check for proptosis and come to the front. Otherwise, you have to go back again. Okay. So proptosis is when there's increased protrusion of eye when looking from above. The eye protrudes beyond the orbital ridge. Okay, the supraorbital ridge. That is proptosis. There's a bulge. Okay. So these eye signs you need to know. Yeah. So ectophthalmos, proptosis, lid retraction, ophthalmoplegia, you have to check the eye movements quickly. Chemosis is like the angry looking like edematous, reddish inflamed looking eye. Okay, just check pictures on that. So these eye signs common with Graves. Okay. And Horner syndrome also can occur when there's like lymph node involvement and stuff. Okay. You can check the mouth for fasciculations of the tongue. And remember this rule, okay? In all the neck lumps, you must examine the mouth. In all the mouth lumps, you must examine the neck. Okay. In the hands, you need to check for tremors, fine tremors. Again, in hyperthyroidism. Then thyroid acropathy in club or clubbing. Okay. This you can see in Graves' disease. Okay. So quickly check for tremors, quickly check for clubbing. Feel the palms, whether they are warm and moist. Okay. Feel the pulse for tachycardia or irregular pulse in hyperthyroidism. Okay. Bradycardia can be seen in hypothyroidism. In hypothyroid, I don't think it's dry and cold as such. You can feel a bradycardia. Okay. Hyperthyroid is warm, moist. There can be a tachycardia, irregular pulse. Hypothyroidism, you might feel a bradycardia when you're checking the pulse. Okay, so in the hands, you need to check for the tremors, clubbing, the palms, and then the pulse. Okay. Advanced cases of hypothyroidism, there might be features of carpal tunnel syndrome, but you won't have time for this, so forget about this part. Okay, don't confuse yourself too much. In the legs, there can be pretibial myxedema, especially in the case of Graves. Okay, and don't miss the tendon reflexes. Okay, that's also a good indicator of this thyroid status. In hyperthyroidism, it's exaggerated. Hypothyroidism, there's delayed relaxation. Okay. Then signs of distal metastasis, your lung, liver, brain, bone. These you can offer, okay? But maybe scalp lumps you can palpate when you're palpating the thyroid from behind. At the same time, if you want, you can just quickly palpate. When you're feeling the lymph nodes especially, at the same time, try and keep any scalp lumps. Lymph nodes you already do when you're doing the thyroid examination proper. Liver, ascites, lung examination, those we can offer. Okay, I don't think you'll have time. In the Longcase, at least try and like auscultate. And at least check for like a hepatomegaly. Then you can confidently say like there was no hepatomegaly and lung signs or like breath sounds or percent equal on both sides, like that you can say. In the short case, just offer. Okay. Horner syndrome, it can be due to the pressure exerted by retrosternally extended goiter or due to metastatic spread. Okay, so ptosis, enophthalmos, meiosis, and hydrosis, all those can occur. Okay. That's the thyroid history and examination. One extra question they can ask is, why does the thyroid move on deglutition? Okay, so if you look at this picture, this is the thyroid. This is the trachea with the larynx on top. Not the most accurate picture, okay? But yeah. So the thyroid is encapsulated or like it's surrounded by this pretracheal fascia. The thyroid is invested by this pretracheal fascia. This pretracheal fascia continues below as the pericardial fascia. Okay, and this pretracheal fascia it's attached to this. When you look at this presacral fascia, it's attached to the larynx. Okay. So when you swallow, your larynx moves up. Okay. So the pretracheal fascia is attached to the larynx, and the pretracheal fascia covers the thyroid gland, encapsulates sort of the thyroid gland. So when the larynx moves up, the pretracheal fascia moves up, the thyroid gland also moves up. Okay, that's why your thyroid moves up on deglutition. Right. Any questions after that? I think history and examination is you know it. Just wanted to rush through it also. Yeah. This is what they expect at the end of history and examination, especially Dr. Langa Pereira at the short case or at the long case. These 6 points, or at least the 5 points, you need to try and summarize it to him. The type of goiter, whether it's diffuse or nodular, if it's a nodular, multinodular, or solitary nodule. The thyroid status, hyperthyroid, hypothyroid, or euthyroid. Okay, are there features of local invasion or compression, like the difficulty in breathing, swallowing, okay, carotid displacement, lymph node involvement, like that. Okay, retrosternal extension and features of malignancy. Okay. With the history, I think you might be able to identify some causes. Because at the end of the long case, you need to tell all 6. At the end of the short case, at least 5. The first 5 you need to tell, summarize. Okay. Anyway, when you're giving a running commentary or something, even you are covering all these points, basically. Then how do you investigate a goiter? Okay. So these 3, the thyroid function test, ultrasound neck, and the FNAC are the main or the basic 3 investigations that we need to do. At the minimal investigations we need to do for a goiter. Okay. So for all the goiters, except for that solitary nodule, the first investigation of choice for the SPS would be a thyroid function test. If it's a solitary nodule, the first investigation in the SBA is an ultrasound neck. Okay, so remember that. I'm telling it again because they've asked you. Right? So why do we do a thyroid function test? We can do a TSH, 3T, 3T4, because we need to assess thyroid status. Okay, so this is because we must make the patient clinically and biochemically euthyroid before surgery to prevent thyroid storm. Okay, so we need to check the thyroid status and treat appropriately to make the patient euthyroid before doing surgery. Okay, then an ultrasound scan of the neck. Okay, so with the ultrasound, you can confirm the goiter and you can assess like whether it's solid or cystic and all that, the nodularity. If it's a solitary nodule, you can see if there are any. If it's a part of a multinodular goiter, you can check the suspicious nodules and all that. And then there are certain suspicious features of malignancy, which you can check from the ultrasound neck. So these also are asked. So those features are like hypoechoic thyroid gland, microcalcifications, absence of halo, lymph nodes that are taller than wide on transverse view. Okay, and also with the ultrasound neck, you can detect clinically unpalpable lymph nodes. Okay, so clinically, when you do the examination, if you don't feel any lymph nodes, the ultrasound might pick them up. Okay. Yeah. Then the next investigation is an FNAC. FNAC, you can use freehand FNAC or you can even use an ultrasound guided FNAC. Okay. If there's a dominant nodule on palpation, you can do a freehand FNAC. But if there's a multinodular goiter and you can't really sort of get the dominant nodule in that, you can do an ultrasound and find out the dominant or the suspicious nodule and get the FNAC from that nodule. Okay. Then FNAC results will be given according to the Bethesda or the THY or the Thai classification. And these are 2 different classifications. They are not the same, but are quite similar. In Bethesda, there are 6 components, and in Thai, there are 5 components. So we'll look at that just to get an idea. So the FNAC is a cytological diagnosis. They just put a needle and aspirate some cells, right? So based on those Based on the microscopic appearance of those cells, they classify it. The Bethesda classification has 6 components. One is inadequate specimen or non-diagnosed. Okay. 2 is benign. All the cells look completely benign. 3 is atypia of undetermined significance. There's some cellular atypia. Okay. 4 is either suspicious for follicular neoplasm or follicular neoplasm. 5 is suspicious for malignancy. 6 is malignancy. Okay. Thai classification, Thai 1 is inadequate, Thai 2 benign, 3 is follicular lesion, 4 is probably malignant, 5 is malignant. So I don't think you need to memorize this, but know that as the score is higher, the chance of malignancy according to this is higher. An important thing to notice is this follicular neoplasm. The follicular neoplasm, according to the Bethesda classification, and this follicular lesion in the Thai classification. Okay. So if the FNAC comes as a follicular neoplasm, or lesion, can be one of two things. Okay. I'll come back to this in a bit also, but I'll tell this now itself. It could be a follicular adenoma or a follicular carcinoma. Right? So follicular neoplasm is what you get from your FNAC. Okay, so the FNAC will only tell up to this level, whether it's a follicular neoplasm or a lesion. Okay. This follicular neoplasm could either be a follicular adenoma or a follicular carcinoma. Okay. So to differentiate these two, you need to do a biopsy. The FNAC will only give this. Okay. To differentiate between these two, you need to do a biopsy. Right? So follicular carcinoma is when you do a biopsy if there's capsular and vascular invasion. Vascular invasion is known as a follicular carcinoma. Capsulovascular invasion is follicular adenoma. Okay, so remember this for now. We'll come back to this in a bit. But FNAC can only tell if it's follicular neoplasm or a lesion. FNAC cannot differentiate between follicular adenoma and follicular carcinoma. To differentiate between follicular adenoma and carcinoma, you need to do a biopsy. Okay, so I'm telling this now because the management of follicular adenoma and follicular carcinoma is different. So just keep this in mind for now. Okay. So these are the 3 basic investigations you need to do for all the goiters. Then in addition, you can do other investigations, especially if you are going to go ahead with surgery. Okay, like thyroid autoantibodies in certain autoimmune conditions, like in Hashimoto's thyroiditis, we check for microsomal thyroid antibodies, also known as thyroid peroxidase antibodies, and also thyroid antithyroglobulin antibodies. For Graves' disease, we check for TSH receptor antibodies. Okay. Before going for surgery, we need to do a X-ray of the neck, AP and lateral. Okay. The AP neck X-ray will show if there's tracheal deviation, and the lateral neck X-ray will show if there's tracheal compression. Okay. Right. Then before we go for surgery, this is mandatory. We need to do an ENT referral and do a laryngoscopy. Either an indirect laryngoscopy or a fiber optic laryngoscopy to assess the status of the vocal cords before the surgery. Okay, because as you all know, with thyroidectomies, There can be injury to the recurrent laryngeal nerve. Okay, and there can be changes in voice. There can be stridor. So before we do a surgery, we need to assess the status of the vocal cords to see if there's any existing sort of vocal cord palsy. Okay, that is also for like legal protection to the surgeon as well. Okay, because if there's any already existing vocal cord palsy after the surgery, if the surgery went well, but if the patient already has some vocal cord palsy, the patient won't be able to take any legal action. Okay, so for legal protection also we need to do this. And say we do a laryngoscopy and there's some vocal cord palsy identified, then the surgeon will need to take some extra precautions when doing the surgery. Okay, like using like magnifying, like those special lenses and glasses to identify the recurrent laryngeal nerves and all that. Okay. Then tumor markers, especially if you're suspecting a malignancy, thyroglobulin for the follicular and papillary carcinoma, and calcitonin for the medullary thyroid carcinoma. And baseline serum calcium can also be done. Okay, so remember these 8 investigations. If you're going for surgery only, you need these imaging, laryngoscopy, tumor markers, and calcium. Okay, if not, you don't really have. Tumor markers, you can do even if you're not doing surgery to get an idea. Okay? Then indications for surgery. In goiters which are proven or suspected to be malignant. Okay, or if there's pressure symptoms like obstruction of airways, where the patient has dyspnea or orthopnea, esophageal compression, and if there's the goiter causing dysphagia. So these are less common or rare because they need to be very huge. And the other reason is cosmetic at the patient request. Okay. Then we'll look at the thyroid cancers mainly today. The types of thyroid cancers. Thyroid cancers can arise from the follicular cells. So those can be follicular carcinoma, papillary carcinoma. Those are the differentiated malignancies. And poorly differentiated malignancies arising from follicular cells are the anaplastic carcinoma. Okay. Then thyroid cancer arising from parafollicular cells are your medullary thyroid carcinomas. Then there can be thyroid lymphomas because the thyroid gland, it has some lymphatic tissue as well. So lymphomas can arise from the thyroid gland. And there can be secondary tumors in the thyroid, commonly from the breast. Okay. Secondary tumor deposits of the thyroid can occur from breast tumors as well. Okay. So now we look at individual carcinomas and their management. So papillary carcinoma is the commonest thyroid malignancy, up to about 75 to 85% of thyroid malignancies. Okay. So it's commoner in the younger age group. Microscopically, there are papillary projections. That's why the name comes as papillary carcinoma. And there's pale empty nuclei known as orphan Annie nuclei. Okay. Papillary carcinomas can be multifocal in the same lobe or in both lobes. Okay. So generally, if we have if there's a goiter, if there's like a right-sided thyroid lobe enlargement, and the FNAC comes as papillary neoplasm, we tend to do a total thyroidectomy because the main reason is because the tumor can be multifocal where both the lobes are involved. So we do a total thyroidectomy. Okay. In papillary carcinomas, the lymphatic spread is more than the hematogenous spread. Okay. So comparatively, the spread is slower compared to follicular malignancy, so the prognosis is better. Okay, so papillary carcinoma is one of the most curable malignancies. Okay, the other curable malignancy is breast carcinoma, provided it's identified early. Okay, so one way to remember is lymph is yellow and papillary it ends with Y, which is for yellow. Okay, so papillary carcinoma, papillary ends with Y, yellow is for Y is for yellow is for lymph. So papillary carcinoma spreads with lymph mainly. There's a subtype of papillary carcinoma known as micropapillary thyroid carcinoma, which is less than 1 centimeter in diameter. Okay. So this small subtypes good to know because the management can vary. Okay, in micropapillary thyroid carcinoma, for example, we don't give the radioiodine therapy. Whereas for papillary carcinoma, we give radioiodine therapy. Okay. Then follicular carcinoma, 10 to 20% of thyroid malignancies, middle-aged and elderly are commonly affected. Microscopically, there are microfollicles with capsular and vascular invasion. So follicular carcinoma is a malignant one. That's capsular and vascular invasion. Here, the hematogenous spread is more than the lymphatic spread. So follicular, it ends with R. R is for red. Blood is red. So the hematogenous spread is more than the lymphatic spread. Okay, so remember it like that. Follicular ends with R. R is for red. Blood is red. So the hematogenous spread is more than the lymphatic spread. So because of this, the prognosis is comparatively poor compared to papillary carcinoma. So mortality is twice that of papillary carcinoma. Then follicular carcinoma also has subtype known as Hurthle cell tumor. Okay. In that, the prognosis is even worse. All right. Then how do we manage papillary and follicular carcinoma? Okay. So there are 4 main steps in this management. Actually, it should be 5 steps. The first step is making the patient euthyroid before this treatment. Okay. The pre-op assessment and making the patient euthyroid, and that general management should go for everything. But specifically, the rest of it has 4 steps in the management. Okay. First step is surgery. Second step is lifelong thyroxine supplementation. Third step is radioiodine therapy. Fourth step is the follow-up with thyroglobulin. So thyroglobulin is a tumor marker for both papillary and follicular carcinoma. Right? So when we take surgery for papillary carcinoma, the FNAC, the investigations we did in the initial stages, I told you we need to do a thyroid function test, the FNAC, and the ultrasound scan. The FNAC can diagnose a papillary carcinoma. Okay, so if the FNAC comes as a papillary neoplasm or a papillary carcinoma, that is good enough for us to do a total thyroidectomy. Even if only one lobe is enlarged or even if it's only one nodule, we do a total thyroidectomy if the FNAC comes as a papillary carcinoma, because the tumor could be multifocal. Okay. So FNAC can diagnose a papillary carcinoma. Okay, so that can be asked in an MCQ, Longcase and stuff. But the FNAC can't diagnose a follicular carcinoma. Okay, the FNAC will come as a follicular neoplasm or follicular lesion. Okay. So FNAC cannot differentiate between follicular adenoma and carcinoma because the FNAC is a cytological diagnosis. Okay. To differentiate between follicular adenoma and carcinoma, a biopsy is needed. Okay. But for thyroid gland, we don't do a true cut or an excision biopsy because the thyroid is very vascular. Okay. There can be a lot of bleeding, and also if we try to do a true cut biopsy or an excision biopsy, there can be seeding of malignant cells and local recurrence. So this is the reason why we don't do a true cut biopsy or an excision biopsy in thyroid. Unlike in breast malignancies, you can do a true cut and excision biopsy. But thyroid, we don't do because it's very vascular and there can be seeding of cells and local recurrence. Okay. So therefore, if the FNAC report comes back as follicular neoplasm, first what we do is a hemithyroidectomy or a lobectomy. So what's the difference between hemithyroidectomy and a lobectomy? Okay. So lobectomy is when we remove a particular lobe of the thyroid gland, either the left lobe or the right lobe. Hemithyroidectomy is when we remove the one lobe along with the isthmus. Okay, either the left lobe with the isthmus or the right lobe with the isthmus. So these terms also you need to know. Okay, so once again, what we do is if the FNAC comes as a thyroid neoplasm, if it comes as a follicular neoplasm, we do a hemithyroidectomy or a lobectomy and then send the sample for histology. Okay. If the histology biopsy report comes back as an adenoma, we can leave the rest of the gland. Okay. Adenoma means benign. Okay, so it's not a malignancy, it's just a benign tumor. We can leave the rest of the gland. It can resolve on its own. Okay. If the biopsy report comes back as carcinoma, we have to go ahead and do another surgery and remove the rest of the thyroid gland. For that, we call it a completion thyroidectomy. Okay? Because we've already done a hemithyroidectomy or a lobectomy. and now the biopsy report comes back as a carcinoma, when we had to go ahead and do another surgery and remove the rest of the thyroid gland. So that is known as a completion thyroidectomy. Okay. So hope everyone got that. Right. So we just go into flow chart and show FNAC. FNAC, if it comes back as FNAC can diagnose a papillary carcinoma. Okay, so then what we do is we do a total thyroidectomy. Okay, the FNAC comes as follicular neoplasm or lesion. We need to differentiate whether it's malignant or a benign, right? So then what we do is we do a hemicectomy or a lobectomy. Okay, and send for biopsy. Okay. The biopsy comes back as an adenoma. That means there is no capsulovascular invasion. Then we can leave the rest of the thyroid gland. It comes back as a carcinoma. We have to go ahead with a completion thyroidectomy. Basic flow chart for follicular carcinoma, follicular neoplasm, and papillary neoplasm. Okay. FNAC can diagnose a papillary carcinoma, but FNAC can't diagnose a follicular carcinoma. It will only come as papillary neoplasm or lesion. Okay. Right. So now we did surgery. I told you there's 4 main steps. So surgery is done. How we do the surgery, what surgery do for what malignancy, we discussed. Now lifelong thyroxine supplementation. So lifelong thyroxine should be given, and this should be high dose thyroxine. And why is it a high dose? High dose because if anyone knows, you can type down so you can say high dose is because this follicular and papillary thyroid malignancies, they are TSH dependent malignancies. Okay. So TSH secreted from the pituitary can sort of worsen the progression of the malignancy. This papillary and follicular carcinoma, they are TSH dependent. So higher the TSH in the blood, the more this malignant cells proliferate and spread. Okay. So our goal of thyroxine treatment is to suppress the endogenous TSH as much as possible. So we need to give a high dose. So why high dose? Because follicular and papillary carcinoma are both TSH dependent tumors. So we need to give high dose thyroxine to suppress endogenous TSH production. Now, what is this high dose? So these doses also you need to know. Okay. Right. So the normal dose of thyroxine supplementation that we give, say it's another patient who has had like a Graves' disease or a benign, like an endemic goiter, and they've undergone a total thyroidectomy. After that, what we give is 1.6 we give thyroxine roughly about 1.6 microgram per kg per day. If the goiter is a benign goiter and we've done a total thyroidectomy, what we generally give the normal replacement dose is 1.6 microgram per kg per day. Patient is left around 50 kilograms. The normal maintenance dose is around 75 micrograms per day. not milligrams. Okay, thyroxine is given in micrograms. Patients will tell you milligrams, but no, it's micrograms. If you go and say milligrams, that's wrong. Okay, so the normal maintenance dose is 1.6 microgram per kg per day. So in a 50 kilogram patient, the dose will come up around roughly about 75 microgram per day. High dose thyroxine means we give 2.1 microgram per kg per day. The starting dose can come up to more than 100 microgram per day. And thyroxine, you need to take it early morning, at least half an hour before the breakfast. Okay, on an empty stomach, basically. Okay, and our target TSH is less than 0.5 milligrams per liter. I think. Not 0.5, less than 0.1. Yeah, it should be less than 0.1. I can't remember the unit. I think it was milligram per liter or something. Yeah, I'll check on that. Drop a message. Okay. So this again, you need to know thyroxine, lifelong high dose thyroxine. Why is it high dose? Okay, because they're TSH dependent. Yeah, I think it's milliunits per liter or something like that. Okay, MU per liter, no? Yeah, thanks. Okay, 0.1 MU per liter. Yes, thank you. Okay. Right, so know these. Okay, they can ask these doses and stuff. Then radioiodine therapy. Okay, so we went through the surgery, then we went to thyroxine, and now we come to radioiodine and the follow-up with thyroglobulin. Radioiodine therapy, also known as ablation therapy. What we use is iodine 131. Okay, this is indicated for follicular and papillary carcinoma, but not indicated for micropapillary carcinoma. Okay, usually given after 6 weeks following surgery. Okay, so 6 weeks following surgery, we can give the radioiodine therapy, ablation therapy. So this, most of the patients may need, but not all of them. Okay, so when you give radioiodine therapy, iodine 131, the remaining thyroid tissue or the metastatic thyroid tissue will uptake iodine 131 and it will emit beta rays or beta radiation and destroy the residual thyroid tissue. Okay. Yeah. But the thing is, before we give radioiodine therapy, we need to stop the thyroxine. Why is that? Because for radioiodine to be taken up by any thyroid tissue, the TSH should be relatively high. Okay. So don't confuse. Before we had to give high dose thyroxine to suppress the endogenous TSH, okay, because its malignancies are TSH dependent. But when we are giving radioiodine therapy, this radioiodine, for the radioiodine to be taken up by any residual thyroid tissue, your endogenous TSH should be high. Okay, TSH should be high for radioiodine therapy. Okay, so in order for your TSH to be high, we stop thyroxine treatment for around 2 weeks before radioiodine therapy. So these small details also they can ask. Right? Okay. And one of the advantages of doing a total or a completion thyroidectomy is it reduces the amount of thyroid tissue in the body. So when there's less thyroid tissue, we can use lower doses of iodine 131. So therefore, there's less adverse effects. So there's quite a few adverse effects with your iodine 131 therapy, like it can cause dry eyes, dry mouth. Okay, it can cause some degree of subfertility, right? And there are some advice that we need to give patients that have undergone radiation therapy, like they need to have an isolated life, like stay in a separate room, keep a particular distance from others for at least 6 months. Okay, especially do not go near pregnant mothers because it's radiation, right? Then advice on contraception for at least 6 months. Okay, barrier methods are good. Okay, advice about common adverse effects like xerostomia, like dry eyes, dry mouth. Okay, that's because the radioactive iodine is taken up by your salivary glands and lacrimal glands as well. Okay, so for some time there can be some dry eyes and dry mouth. And their clothes, plates, cups, and stuff, they need to be washed separately. Okay, because in their bodily secretions, the iodine 131 can be present. Okay, so when we are giving it, I don't know if you've been to the Upper hospital, they have separate rooms and sort of isolation areas, like quarantined areas where they give radioiodine. They're like, even like the food is given separately and all that. Given the waste is disposed separately. But when you discharge and send them home, you need to give this advice. Okay, so these also they can ask. Then thyroglobulin is the tumor marker for both papillary and follicular carcinoma, so you can follow it up with thyroglobulin. Ideally, after surgery and radioiodine therapy, the thyroglobulin level should be 0 or near 0. If it's high or increasing, you need to suspect local recurrence or metastatic deposits. Right? So that is it for the management of follicular and papillary carcinoma. Are there any questions for those two? The follicular carcinoma management is the confusing one because you need to do the FNAC, then you need to do hemithyroidectomy, and then depending on the biopsy report, you do the rest of the surgery. Okay. Right. We go to anaplastic carcinoma. Anaplastic carcinoma is highly malignant and locally invasive. Prognosis is very, very poor. Survival is calculated in months. Okay, this is the complete opposite of papillary carcinoma. Papillary carcinoma prognosis is much, much better. Okay. The disease is confined to the thyroid. You can do a total thyroidectomy, but even then, the survival rarely exceeds 6 months. Okay. Radiotherapy should be given in all the cases. Medullary carcinoma is neuroendocrine in origin. It's a tumor of neuroendocrine origin. So I'm sure you've heard of this neuroendocrine tumors, but what is a neuroendocrine tumor? Okay. These are cancers that begin in specialized cells called neuroendocrine cells. So neuroendocrine cells are cells that have similar traits to those of nerve cells and hormone-producing cells. Okay, so these neuroendocrine cells are examples of neuroendocrine cells are your parafollicular C cells, from the clear cells in the thyroid gland. Then another example is in your adrenals, right? Adrenals also has neuroendocrine cells. Tumor marker for medullary thyroid carcinoma is calcitonin. Okay, main one is calcitonin. CA also sometimes might increase, but mainly we use calcitonin. Both hematogenous and lymphatic spread occurs. Right? So neuroendocrine tumors can be associated with multiple endocrine neoplasia, what we call MEN syndrome. Okay, there are different types. The medullary thyroid carcinoma is found in MEN2A and MEN2B. Okay, so just know the other associations as well, like MEN2A, you have parathyroid hyperplasia or hyperparathyroidism, and pheochromocytoma. Okay, MEN2B, you have Marfanoid body habitus, something like in Marfan syndrome, like that kind of body. And there can be pheochromocytoma as well. So the important thing is, with medullary thyroid carcinoma, this pheochromocytoma also can be associated. So in every patient with medullary thyroid carcinoma, you need to screen for pheochromocytoma. Okay. MEN1 has pancreatic tumor, pituitary tumor, and parathyroid tumor, parathyroid hyperplasia. So in all the cases of medullary thyroid carcinoma, pheochromocytoma must be excluded by measurement of urinary catecholamines. Okay, that's the urinary VMA levels. We can do an ultrasound abdomen as well to detect any adrenal masses. Okay, and family screening should be done. Okay? Treatment of medullary thyroid carcinoma is by total thyroidectomy. You can even do prophylactic lymph node dissection. Okay. prophylactic or curative lymph node dissection. In children who have been diagnosed with MEN 2A or 2B, you can do a prophylactic thyroidectomy even at a very young age. Okay, so these also can be an MCQ. There is a place for prophylactic thyroidectomy before they develop the medullary thyroid carcinoma in patients already diagnosed with MEN 2A and 2B, even in children. Okay. Thyroid lymphoma. This site on the thyroid tissue has lymph. Thyroid has lymph as well, lymph tissue as well. So you can get lymphomas from them. Okay, lymphomas generally respond well to radiotherapy. Surgery may not be needed. Okay, if they respond well to radiotherapy, surgery is generally not needed. If the lymphoma is confined to the thyroid, the prognosis is good. But if there's widespread malignant lymphoma, like say there's lymphoma in the thyroid, there's axillary lymph node enlargement, there's what do you call internal lymph node enlargement. Okay, if it's widespread lymphoma, the prognosis is worse. Right. So those are the malignancies and the managements, summaries of the management. Then we come to complications of thyroid surgery. Okay, these are also commonly asked. One is you can get nerve injury. Okay, that can be injury to the superior laryngeal nerve. This can lead to loss of pitch of voice. Patient can have a dull voice. Okay, so when you're taking consent for thyroidectomies, you need to stress on these. Okay, there can be loss of pitch of voice. Okay, there can be recurrent laryngeal nerve injuries, difficulty in breathing, hoarseness of voice. All those you need to tell. Okay, yeah, loss of pitch of voice or dull voice. That is because this superior laryngeal nerve innervates the cricothyroid muscle, and cricothyroid muscle helps to give the pitch to the voice. Okay, so important if they're like singers and stuff. Then recurrent laryngeal nerve injury. Recurrent laryngeal nerve injury can occur in many ways. It can be bilateral or it can be unilateral. Okay, and again it can be complete or it can be partial. Okay? So if it's bilateral complete recurrent laryngeal nerve palsy, okay, that means on both sides the recurrent laryngeal nerve is completely injured. Okay, that means the patient can't move his or her vocal cords. So he won't be able to talk. Okay? That is known as aphonia. Show some diagrams. Just look at the diagrams. You don't need to look at this part much. It's a similar explanation, but bit different. So if it's bilateral complete recurrent laryngeal nerve injury, the vocal cords are in somewhat of a neutral position. Okay. Yeah, bilateral complete, both cords are in neutral position between abduction and adduction. Okay. So here the vocal cords can't move about. Okay. So the patient can't sort of, there's aphonia. They can't talk. Okay. That is bilateral complete recurrent laryngeal nerve pause. Okay. If it is bilateral partial recurrent laryngeal nerve palsy, you get a severe stridor. That is known as Simon's law. Okay. That is because with partial injury to the recurrent laryngeal nerve, the abductors, the muscles that move the vocal cords away from the center, the abductors are affected before the adductors. Okay, right? So let me draw it. Okay, in partial palsy, the abductors are affected before the adductors. Okay, so say this is the normal position of the vocal cords. Okay. So in partial paralysis, when the abductors are affected more than the adductors are taking over, right? So this vocal cord will move towards the center. They are adducted. Okay. And since it's bilateral, it happens on both the sides. The vocal cords are both closer together. Right? So this gap is very narrow. So you get a severe stridor. Okay. Yeah. Then unilateral complete recurrent laryngeal nerve palsy, you can have hoarse voice, or they may be asymptomatic. Unilateral partial recurrent laryngeal nerve palsy also, they can have a hoarse voice, may have a stride. Mainly know this, bilateral partial recurrent laryngeal nerve palsy gives rise to a severe stridor. That is Simon's law, okay? In partial paralysis, the abductors are affected more than the adductors, so the vocal cords are in the midline, okay? This time. So we'll go through this slowly, okay? Right. Then another complication is hypoparathyroidism. Okay, so hypoparathyroidism can occur due to ischemia to the parathyroid gland or accidental removal of the parathyroid glands. Okay, so with hypoparathyroidism, we can get a hypocalcemia. So ideally, serum calcium should be checked around 24 hours after surgery or within the first 24 hours. Okay. Normal serum calcium is around 2.1 to 2.6 millimole per liter. Mild or asymptomatic hypocalcemias usually don't require treatment, but you will have to monitor them and keep. If symptomatic or serum calcium is less than 1.8, you have to go IV calcium. So that's how you give is IV calcium 10%, calcium gluconate 10 ml over 10 minutes, followed by oral calcium, that is calcium lactate or carbonate, 1 tablet daily. You can combine it with 1 alpha cholecalciferol and send blood for calcium. You can't discharge the patient until the calcium has until the calcium has normalized for at least 24 hours. Okay, so I think there's an SCQ on this, so like hypocalcemia and following thyroidectomy. Then hypothyroidism, obviously, after total thyroidectomy, you need lifelong thyroxine. Okay, thyrotoxic crisis is a life-threatening hypermetabolic condition due to high thyroxine levels. It occurs due to inadequate preparation of the patient prior to surgery. Yes, so there's inadequate preparation prior to surgery. When you're doing surgery, there can be sort of rapid influx of thyroxine into blood, and you can get a thyrotoxic crisis. Okay, so you have to manage the patient as an ICU or HDU setting. Resuscitate, assess airway, breathing circulation, give oxygen via face mask, give IV fluids, IV hydrocortisone, barbimazole, glucose, iodine, IV propanol. Basically, give the antithyroid agents, carbimazole with hydrocortisone, propranolol, and glucose iodine to reduce the vascularity. You can cool the patient with ice packs. If the patient develops heart failure, you can use diuretics. If there's atrial fibrillation, you can give digoxin. Okay. Then airway obstruction, most important complication. Okay. This is also depending on the time period. There are different causes. Immediately, there's airway obstruction following surgery, or immediately if there's stridor or difficulty in breathing upon extubation, the cause is tracheomalacia. It's a rare cause. Okay. If there's stridor occurring immediately after surgery, main cause is tracheomalacia. But this rarely occurs. Okay. This is because with long-standing multinodular goiters or malignant goiters, there can be softening of the tracheal cartilage. Okay. Before the surgery, the goiter acts as a supporting structure, but soon after extubation, the trachea collapses. So how we manage this is we have to re-intubate. Okay, we'll re-intubate, stabilize, and then later on, slowly try and extubate. Okay. Within few minutes, it could be bilateral partial recurrent laryngeal nerve palsy. Okay. For this source of management is re-intubation, and the definitive management is we have to ablate the adductor muscles. I told you the adductor muscles are the muscles that bring the vocal cords to the midline, so we need to ablate those muscles, the arytenoid muscles, by laser ablation. Okay. Within 24 hours, if there's stridor occurring within first 24 hours, main cause is laryngeal edema. Laryngeal edema can be occurring due to two reasons. One is due to excess handling during surgery because of traumatic intubation or surgical manipulation, or this is the commonest cause, bleeding and hematoma developing deep to the deep cervical fascia. Okay, there is some amount of bleeding when you're doing surgery. There's primary hemorrhage, reactionary hemorrhage. and there's some amount of bleeding, and this bleeding is deep to the deep cervical fascia. Okay, so after the bleeding, there's a hematoma that develops. Okay, this hematoma can compress laryngeal veins, and it will block laryngeal venous drainage. So when the venous drainage is impaired, there's laryngeal mucosal edema. Okay, this is the most common cause of airway obstruction or stridor in a patient within first 24 hours after thyroidectomy. Okay, so management is we have to remove the sutures in the ward to release the pressure, evacuate the hematoma. Okay, we need to immediately attend to the patient. We need to call for help, prop up the patient, assess the airway breathing circulation, connect the patient to at least a pulse oximeter, right? And since this tension hematoma is the commonest cause, we need to remove the sutures. We need to remove the dressing in the ward. Look for any bulges. Okay, we need to remove the sutures and put using a gloved finger. We need to put our finger in and remove the hematoma. Okay, then try and intubate the patient. Take the patient to the OT as soon as possible. Inform your seniors, anesthetist, blood bank, everything. Identify and stop the bleeding vessel. Okay, so this would be the definitive management intubation. And take the patient to the theater, identify and stop the bleeding vessel. Okay. More than 24 hours, hypocalcemia is the commonest cause for stridor. Okay, hypocalcemia occurs due to hypoparathyroidism. With hypoparathyroidism, serum calcium reduces, and that can lead to spasm of laryngeal muscles. Okay, management is the management I told before, IV calcium, 10 ml, 10% over 10 minutes. Right? So once again, stridor management, the definitive management depends on the underlying cause, but generally what they will ask for is this, okay, this bleeding and the hematoma developing and the laryngeal edema. So in that, what you need to do is, if the nurse is someone close, you need to immediately attend the patient. Okay, you need to run to the ward if you are not in the ward. Go pop up the patient, assess the circulation, right? Connect the patient to at least a pulse oximeter, inform the seniors, everything. Remove the dressing, see if there's any obvious bulging. Because sometimes these hematomas can be big and there can be some obvious bulging in the neck. You remove the sutures in the ward itself. Okay, there's no time to take to the theater initially. You remove the sutures in the ward itself. Okay, you wear your gloves and stuff. Obviously, you remove the sutures. Put like one finger in and try to feel for and remove the hematoma. Okay, so you have to remove the hematoma. Then inform your seniors, theater, anesthetic, blood bank, send to the OT as soon as possible, intubate. Okay, and you have to reopen the patient. And what you do is you have to identify and stop the bleeder. Okay, and you give blood transfusion if there's severe bleeding and all. Okay, and there might be some place for nebulizing adrenaline and IV hydrocortisone. Also, there might be some places, but before that, mention the removing the sutures, removing the hematoma, intubating, and all. Okay. Yeah, can the HO remove the suture? Yes, the HO has to remove the suture because you can't. Okay, if you are the on-call HO, seniors might not be in the hospital premises, so it's your duty. Okay, that is our responsibility. So post-op thyroidectomy, very important. Even if they develop a little bit of difficulty in bleeding, you need to be on high alert. Okay, you need to monitor the patient. If you think it's a tension hematoma, if there's some amount of bulging in the neck, if the dyspnea is worsening, right? You need to remove the sutures. You can do it in the ward itself. The HO can do it. The HO has to do it. Okay? Yeah, we need to remove the skin sutures, the deep muscle sutures, strap muscle sutures. You can put a gloved finger in, remove the clot or remove the hematoma. Try and intubate. It might be difficult to intubate the patient in the ward, so you have to take the patient to the theater. Anesthetist or MO anesthetist can intubate. If no one's there, you can intubate. Okay, and then somehow then for the surgical part, the surgeons should come. Some senior should come and identify the bleeding vessel and ligate or whatever stop the bleeding vessel. The HO can remove the sutures in the bone. Yeah, that's it. If there's any questions, we can ask. Pre-operative, you don't need to reserve an ICU bed for all the thyroidectomy patients, okay? But after, say the patient has come post-op following the thyroidectomy and they develop tension hematoma and they're stridor and stuff, and they go back to the theater, you intubated, you need to identify the bleeding vessel, then yeah, then you can put the patient into the ICU because the patient has developed stridor. But routinely for all the thyroidectomy patients, don't need to require an ICU bed. Okay. ICU bed is mainly important for like those big surgeries like the esophagectomy, gastric CA, those whippers. Okay, those ones ICU bed is important. AR, APR, those stuff. Thyroidectomies, you can manage them in the ward. In the ward, the acute side, or even if the ward has an HDU, then better to put into the HDU. Okay, but routinely ICU not need. Yeah, I'll send all the notes on the group. Okay then. If there's any questions, just drop me a message. All right. Thank you guys. Good night.
Thank you, bro. Goodbye, bro.
No problem. Good night.